So, can you read the stem? This is a clinical station for you.
Okay. Matilda is a 3-year-old girl who attended the clinic today. Please perform a general physical examination, concentrating on her skin.
Yeah. So you have 3 minutes for the preparation. Okay, I'm giving you. You don't get in the exam. Okay, I'm giving you, and after that we'll start. Yeah.
Yeah. Okay.
Okay. So, do you want to start?
Yeah. Yes, we can start.
Yeah. Go ahead.
Good evening. I am Dr. Dinesh. I will wash my hands and then enter the examination hall. Am I talking? What is the name of the this thing, mother? Matilda is 3-year-old girl.
Name of the mother is Lini.
Okay. Am I talking
L-I-N-I.
to Lily, mother of Matilda?
Yeah.
Can I
Yeah.
can I
This is Lini.
examine? Yeah. Can I examine your child?
Yes. Yes, doctor.
Okay. I would like to first know about this thing, Lily. What are the is she having any dysmorphic features?
You can see in the pictures.
Okay, there's a rash on the left side of the face. And what about her dimensions like weight, height?
Weight is on the 25th centile. Height is on the 9th centile. Head circumference is on the 25th centile.
Okay. And is she having any distress like respiratory problem or this thing? Or is she comfortable?
Yeah, compatible, not distressed.
And any devices attached to her in the form of oxygen or anything like that?
No, no.
Okay. Is she alert? Like if I, hello, Matilda, how are you? She replies if I ask her this thing.
Yeah, so she's responding. She's saying she's doing good.
Okay. And now I would start my examination, general examination. Is there any pallor, cyanosis, or clubbing?
No.
Okay. And Is there a presence of any other rash that I can see on the picture other than that on any part of the body, like any hypopigmented lesions or hyperpigmented lesions?
No, you can't find any other similar things.
Okay. Then I would like to examine her nails. Is there presence of any periingual fibromas or any swellings over the nails, nail beds or anything like that?
No, not there.
Okay. Then I would like to examine her eyes. In the eyes, I can see the iris is normal and pupillary reaction is normal.
Okay. Yeah,
And is there presence of any swellings in the neck, any lymph node palpable?
not there.
Okay. And what about the lymph nodes present in the axilla? Are there lymph nodes palpable in the axilla or any other area?
Not significant.
Then I will come to the face. On the face, I can see the rash over there. There is a erythematous rash which is occupying the left side of the face, and it is extending over the maxillary area and also involving the towards the eye. Is she having any itching over the rash? And what about the skin over the rash?
Yeah, no itching is there. Skin over rash is yeah, it's very smooth.
And the size of the rash,
Yeah, it's around 10 by 12 centimeter.
it is around 10,
10 by 12.
10 by 12.
Mm.
Okay. And is the skin over the rash warm to touch or anything?
Yeah, so little bit warm compared to other parts of the body.
Okay. And now I would like to see the back of the child. Is there any scoliosis present?
Yeah, there is a little scoliosis.
Scoliosis towards which side?
Left side.
And when I ask her to bend, the scoliosis disappears or it persists?
It remains.
Okay. And is there any scar mark over the back?
No other scar. No scar marks.
Okay. And is there any other scar mark on the face or over her abdomen?
No.
Okay. Now I would like to examine the gait of the child. Can she walk normally?
Yeah, she can walk normal.
Okay. And I would like to do the this thing examination of her mouth. In the mouth, what about the dental condition?
Means dental condition means what?
Is there any presence of dental overcrowding?
No,
Any high arched palate?
not there.
Hygiene is also normal.
Yeah.
And when I do the examination of the body, like is the child having normal movements of the both the sides? Like is the tone normal?
Yeah, it's not. It's not.
There is no weakness of any part of the body.
So what is your task?
General physical. Okay. And now I would like to examine her this thing uh, abdomen. The rash is only over the face, no other place.
Yeah. Okay. So could you please summarize your findings in the examination and tell the diagnosis?
Yes. Today I have examined child Matilda, a 3-year-old girl who uh, who is having who is not having any dysmorphic features. So her weight, height, and head size is normal, and she's not distressed, and no devices are attached. On examination, I can see a rash over her face, occupying the left part of the face, and also around the eye. And the skin is warm to touch, and size of the rash is 10 into 12. And on the back, there's some amount of scoliosis towards the left side. And other than that, there are no positive findings. There are no other hypopigmented or hyperpigmented lesions over the skin. There are no periingual fibromas. And from what I could gather from the general physical examination, gait of the child is normal, and there is no dental
What is your
overcrowding.
impression? What
Impression,
is your impression?
going by these findings, most likely it is a case of Sturge Weber syndrome, and the child is having a port wine stain over the face.
Okay, okay. Any other differential diagnosis you can put it over here?
Differential diagnosis for Sturge Weber syndrome, we can keep as there is one syndrome known as faces syndrome, in which there are posterior fossa tumors and with presence of hemangiomas over the face. And then there is one Casaback-Marriott syndrome, in which we get the port wine stain with the thrombocytopenia.
Okay, okay. All right. So how do you manage Matilda now?
First of all, I would like to take a focus history, in which I would like to see whether the child was having any other complaint other than the rash, whether at any time she had any seizures or she had any decreased movement of any part of the body. And I would like to assess her mental development. And after taking the focus history, I would like to do few investigations in the form of I would like to get an MRI done and of the brain, and also get an EEG done if there's any history of seizures.
Why you want to do MRI, EEG?
EEG, because many of these children, they have seizures. So if seizures are present, so then we can see which type of seizures are there in the EEG. And MRI, because in these cases, there can be angiomas in the brain, which can lead to hemiparesis and other problems. So we have to see for that.
Okay. All right. So with MRI, is there anything else? The brain? Meningioma? You told some leptomeningium, something you told? What you told?
Yeah, there can be leptomeningiomas.
Okay. So how do you manage them?
Further management depends on the condition of the child. If she's having seizures, so then we will have to give, it is going to be a multidisciplinary approach, in which the doctors will be pediatrician, there'll be a neurologist, there'll be a dermatologist, and then there can be other people depending on the condition. If she's having any difficulty in walking, so we will need physiotherapists, occupational therapists for her activities of day-to-day living.
What is acute emergency in these cases, and whom do you want to refer?
We would like to refer to this thing ophthalmologist. There can be presence of glaucoma, and which can affect the vision, and so we have to be we have to see for that.
Sure. Okay. So your session is over.
Okay.
Your exam is over. Okay, guys, open your cameras for the discussion. Okay, Dinesh. So you tell us how you did, and so how you could have done.
At certain points, like I was feeling, I was not able to express fully.
Why? Yeah. So fully means how much? What extent you wanted to express?
In more detail.
Okay. Okay. Okay, guys. So give feedback to Dinesh so that I can give marks to him. Yeah. How was he? See, everybody is afraid of you, Dinesh. Huh?
No, not at all. No, not at all.
Dr. Dinesh, the discussion was always good, but summary part, summary for both the cases was not good. It was as good as half history. So
Yeah, I agree. I totally agree. And that's why I was trying to stop him, intentionally 2, 3 times.
yeah, and
Yeah, go ahead.
history. You didn't take a diet history in that thing, and weight and diets, a few things.
Diet and weight, though I asked.
Actually, you asked, then I missed.
Yeah, diet, though I asked, and weight also. And
Baki, this everything summary is problem.
Summary, you have to make it very sweet and short. Okay,
yeah.
it has to be crisp. Okay, you understand crisp?
Yeah.
What do you mean by crisp?
I don't have any right to say because mine was very burst, but still, if asked, I can tell. Even the
Oh,
there
he
is
doesn't mind. Okay, so he doesn't mind. Don't worry.
communication. Communication empathy was very less.
This time, though, I apologize for.
No,
Yeah.
there was
more than I can.
No, I think okay.
I can.
Okay, we'll do one thing. Yeah. We will start one by one. Okay, we'll start one by one. Yeah. So yeah. Your developmental station, 2-year-old. Sorry, what was that? What is that?
2-year-old John with delayed walking.
Yeah, 2-year-old John.
Yes, yeah. Yeah. Okay, so you tell me, how was it? What did you find? Did you find any difficulties?
Actually, this case, I was thinking from the beginning itself, it was something related to motor, this thing like some muscular problem. So, but slight this thing delay was there in other milestones like this thing hearing and all. But that can be there. Otherwise, I think it was okay.
Yeah, the history taking was okay, but certain times you were asking the motor milestones. I don't know why you were asking. Okay.
Yeah.
So,
actually, only starting. Yeah. Then I changed my thing. Right.
Yeah, and certain questions you are asking again and again. That has happened. Yeah, some admission, something, so twice you ask, I think, treatment and that admission actually. Yeah, otherwise the history was good. Okay, yeah, and again the issue is the summary. So while summarizing, you don't have to give the yeah. So you just have to say that he's having 2.5 years old, so and so. What was the issue? So the concern is about the gait and walking, isn't it? So, so today I got opportunity to take history from Jacob, who is a father of Sean, who is 2 years old. So having concern for the gait and walking, okay, and by history, so he's having the other domains like speech, language, and the social milestones looks normal for the age actually. There's not much of delay there, isn't it? It's normal. Yeah. So, however, there is a significant history of the maternal brother, isn't it? Maternal brother so died because of the similar issue. That is one thing which is very, very important. Yeah. So, putting all these two, otherwise, nothing significant in the family social history and things. So, putting all these together, so I feel John is having isolated, probably isolated motor developmental delay. However, I would like to confirm further by the assessment. That's it.
Okay.
You telling even normal also, you try to put it in the summary. Don't put it in the normal things in the summary. Yeah.
Only the positive findings.
Positive findings. Okay. So after that, you introduce yourself, you took permission, and after that you went ahead and tried to select it twice. And so after twice you went to test the vision, and then suddenly in between you realize that you missed the general observation things.
Yeah.
Okay, it was little bit going forward and again coming back like that thing. So you do the general observation first itself, and
that I realized later on it was totally missed.
Yeah. Yeah, otherwise, so the assessment was good, fine motor, you did everything, and your child was able to pull things in the pincer grasp and some scribbling actually, not that great, and able to make tower of 2 to 3 cues and able to turn the pages, multiple pages at a time, and so yeah, and after that you went ahead with the grasp motor. So you try to check the gate first, and in the gate you probably this gate you could have done before itself, no problem. Yeah, after general observation you could have done. That's okay, no problem. So then you ask the child to walk with you. You check the gait and walking with the actually stiff gait. Actually, you can say not able to run, not able to kick, not able to catch or throw anything. Yeah. So yeah, after that, anything else? Yeah, going upstairs. You asked actually very good. Yeah, so going upstairs because the crawling was there, isn't it? So 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 putting all these two together. So what is the developmental age? Is around you can put it like 15 to 18
15,
months.
yeah.
15 to 18 months. You told something 2 years or something you told? No,
No. 18 months.
you corrected back. Okay,
No,
so 15.
then
No,
corrected.
that was initially.
Then corrected.
Yeah, yeah, corrected. Yes, yes. Okay, all right, and so again here summary. You need to summarize very short, like we discussed already actually. Okay, so so and so. Okay, today is able to do. Okay, no. So otherwise, in general observation, nothing significant. Is moderately built. Okay, not having any dysfunctional features and nothing in the surroundings. Today is able to perform so and so activities. So his developmental age for the fine motor as well as grasp motor is 15 to 18 months. That's it. Okay. So no thing is you found Gover's hand and pseudohypertrophy of the calf muscles. Yeah. So putting all these together, so my diagnosis is probably it's a muscular dystrophy. You told myopathy is that muscular dystrophy. You have to say, muscular dystrophy. In that actually Duchenne muscular dystrophy. Yeah. So,
but we can call it a myopathy also, no? Because muscular dystrophy is basically type of myopathy.
Yeah. Yeah. So
Yes,
if you say myopathy,
examiner.
yeah, myopathy, then I'll think what comes in my mind is Nemeline rod myopathy. All those things will come in my mind actually. Yeah. So
If female child, you
Central.
can say myopathy, but in male child, you should say dystrophy only.
Better, yeah.
You just put it like I'm thinking muscular dystrophies.
Muscular
Okay, then
dystrophy.
Most
myopathy.
likely.
Most likely myopathy you can keep, no issues. I don't have any problem. You can keep it can lead to isolated motor development. I agree with you. But something else you told in the achondroplasia. Why did you put achondroplasia?
No,
Suddenly,
that was matlab, in the end, like with other.
please don't put that. Okay.
Yeah.
Okay.
So for differentials, though, then we will keep Duchenne's muscular dystrophy and congenital myopathies.
Then you can keep maybe SMA type
Rickets.
3, maybe rickets or something like that. You can also put it together. So because the Gower sign was positive for the Gower sign, you can put it.
Yeah, rickets.
Maybe bilateral DDH, Gower sign, rickets, SMA type 3. Yeah, you can put these things. Even limb girdle muscular dystrophy also you can put it there. Okay, Baker's usually comes late. So
that is why I did not mention, because that will be this late presentation.
Yeah.
Child is just 2 years.
Yeah. And so they might ask you about what are the causes of the bottom shuffling, delayed walking. Okay, so basically, bottom shuffling causes could be because of the muscular dystrophy. Duchenne muscular dystrophy is very important. You need to rule it out. Okay,
Neural tube defects.
Yeah, spastic diplegia, neural tube defects. Very good, very good. And what else? DDH. Yeah.
DDH. Yeah.
Yeah, and it could be normal variant.
Normal variant.
Yeah, so that question they might ask you, but I didn't ask you because I think last mock we discussed about that actually. And after that, how do you manage this child? I asked you after taking history, I would like to do the complete neuro. So I would like to plot weight, height, head circumference, you can say, and document vitals and do complete neurological examination. It should come complete neurological examination. Okay. So you told some MSK examination. But after neurological, you can say whatever you want to say, other system examination like MSK something. But neuro has to come first. Okay. You want to do neuro examination, isn't it? That is must first.
Yes.
Yeah. Then after that.
Actually, why I said MSK was I was thinking like tuitions they usually ask in MSK, so I thought it be better to say. But yes, neurological is important.
After neuro,
Yeah.
you can go ahead and do it, no problem.
Yeah.
Okay. Because unless it don't get caught.
Yeah.
Okay. Then yeah, the management is multidisciplinary team, and you know all the members, and basically you need to say I would like to have got the previous patient file investigation, blood investigation, anything done, any genetic testing done. You have to say informing consultant, and so for the confirmation diagnosis CPK, dystrophin gene mutation study. In certain exceptional cases, muscle biopsy. So you have to say for the when CPK level is unequivocal, or when genetic testing is not conclusive, and the management of multidisciplinary team approach, OTPT, this is very, very important. You need to say P flow meter. It's actually 2 years old. Later, so lung function test I would like to monitor. I would like to do ECG, echo, because risk of cardiomyopathy, rhythm disturbances could be there. Yeah. So school is if there is a for that orthopedic consultation, maybe correction. Then so treatment is medical and supportive management. Medical, you have to say prednisolone, diazepam. What was the newer medication?
Etalurin you can use.
Yeah, okay. Very good.
Exon skipping drugs.
Yeah, there is one more drug actually. So,
LV days.
yeah. LVDs. Okay, this is recently
Gene therapy.
appeared. Yeah, it's a dystrophin gene therapy. Yeah. Okay, and genetic counseling for the family is very important. I would say this is excellent recessive condition. Yeah. So for the future, for pregnancy, you need to develop. Okay, so out of 12, I will give you 10 out of 10 out of 12.
Okay.
Okay, so
yeah,
you know the things, but only thing is that certain things in the assessment you are doing little bit, and it's your summary has to come little bit short and brief. Yeah. Then history taking management plan. Yeah, it was good. You use certain respiratory illness and certain things, jargons you use. Okay. You ask certain questions again and again about the whatever certain common questions about certain questions you ask about some respiratory infection again twice. Twice you ask, I think. Yeah.
No, actually, I was. You gave me the history of this thing, bronchiolitis, 6 months. But I was trying to make out.
You initially asked actually, and again at the end again you asked the same thing.
Actually, again, why I was thinking was whether any easy episodes were there other than that bronchiolitis.
Yeah. Okay.
Actually, in these cases, no, the relevant history is very this thing, less. So I was just trying to take more.
So what is important is onset, course, duration, progression. What makes it worse? What makes it better? Okay, that's very, very important. And day-to-day activities that affected, sleep affected, not feeding affected, not the fever is there. Okay, about the details about the fever, skin oozing, the first discharge is coming. You need to ask about that. Okay, what is the treatment going on? You didn't inquire about the treatment here. Exactly what treatment is going on. Okay, since 4 months is treatment going on, what exactly emollients are being used, or creams, ointments. Okay, so exactly
names.
How many?
Okay.
So how many times? Yeah, because steroid cream. How do you know this is particular steroid or antibiotic cream or ointment. We don't know. Okay, so whether child is whether you are applying steroid cream regularly, are you missing any time? Yeah, this is very important. Okay, and so what makes it worse? You have those things actually. So what are the triggering agents and about details about the food history, diet history? Very good. Okay, the child had allergy to what? Peanuts,
Peanut.
isn't it? Yeah. Okay, then there is a strong family history of asthma, hypothyroidism, isn't it, in the family?
Yeah,
Then
mother is having.
yeah, and systemic review as past history, birth history was okay. So one more thing is growth and developmental history is important. Okay, why? Because in case of immune deficiency, you might get delayed milestones and you get recurrent
Yeah.
infection, failure to thrive. That is very important, especially Job syndrome and in case of Scott-Aldrich syndrome. Very good. Okay, so then about the family history you asked, and otherwise it was good. I liked it, but in the discussion part, differential diagnosis, yeah, so it is acute exacerbation of atopic eczema.
Yeah.
Atopic eczema, you have to say, okay, and associated to secondary bacterial infection. Yeah, isn't it? You have to say. So when child is already known case here, so you may not have to give give the other differential diagnosis. Already it is finalized, you know. So already probably somebody has ruled out hyper IgE syndrome and Scott-Aldrich syndrome and whatever. Yeah. So here then you have to give maybe compliances for maybe some there are precipitative factor. Both parents are smoking. You didn't ask about carpets and pets and at home. That is very important. What about using towels? Yeah. So how do you apply? How many times you
Towels?
apply?
Yeah, towels I asked, but yeah, beds and carpets.
Yeah. So these things are important and
But if the examiner is asking differential to them, so we have to mention.
already known case of atopic eczema is there, then you have to say probably infection. Infection in that, okay, staph infection or eczema herpeticum is other thing you have to think of.
Yeah.
Then poor compliance, okay, then maybe so a lot of triggering agents are there, okay. So then underlying food allergy is there. So yeah, so maybe child is using same towels with other kids and yeah, so these are things which are contributing for the poor compliance and recurrent exacerbation of the atopic eczema. Okay, so otherwise, if newly diagnosed, then other DDs, contact dermatitis and psoriasis, another you can give maybe hyper IgE, then that time is got Aldrich, food allergy, those things you can give. Yeah. So management wise, first you have to say, I would like to examine. You didn't say, I would like to examine the child. Directly you started with the multidisciplinary approach. Correct? So first of all, I would like to plot weight, height, and head circumference and the appropriate core charge, document the vitals, including blood pressure, pulse. Perfusion also you have to say, it's very, very important because they will go into sepsis, septic shock, cellulitis. Yeah. So check the hemodynamic status of the child by checking pulses, perfusion. Yeah. So general activity of the child. Yeah. Then after that, yeah, so cardiovascular examination, abdomen examination, yeah, then skin in detail examination. You have to say, I would like to examine. Okay. Then so you have to say, I would like to look at the previous patient file, what treatment is going on exactly, and how is it, yeah. So whether that is there any steroid cream which is prescribed and how much dose you have to check it for that actually. Then inform your consultant, and this is one condition where you have to involve the dermatologist here. So means whenever there is a secondary bacterial infection, whenever there is a eczema herpeticum, you need to involve the, or when you are uncertain about the diagnosis, you need to involve the dermatologist. Okay, so yeah, here definitely I agree with you. It's a multidisciplinary team approach. Other than GP, community pediatrician, yourself, and so dermatology has to be there, and dietitian has to be there.
Dermatology I mentioned.
Yeah, dietitian also you mentioned, very good, because you need to give the food which is which are the food which has to be avoided. Yeah. So what are the foods which have to be given for the child? Yes, sir. One more thing is you can also keep cow's milk protein intolerance also. So it can present like this, Shiva, and recurrent chest infection. Okay, so that is also very important. And yeah, first of all, how do you manage after this? First of all, general measures. Okay, so general measures, keeping nails short. Okay, so using separate towels, and that is very, very important. And then you need to say the emollient, yeah, should be used after taking bath. Okay, so sufficiently you need to use it. At least I think some weekly, some 200 grams, something is written. I don't remember exactly. Okay, so one is emollients, and second thing is yeah, so steroid cream based. So this is probably a secondary bacterial infection. Okay, with the, you can say moderate kind of eczema, atopic eczema with skin infection. So first of all, I would like to start the antibiotic. You said rightly, after sending all the blood culture, inflammatory markers. Yeah. So full blood count, and maybe swab, you have to say, on the skin, that rash. And so flucloxacin is a drug of choice, and local antibiotic creams also very good. So after 48 or 72 hours, the once infection is better covered, then I would like to start the steroid creams. Over the face, 1% hydrocortisone, I agree. Yeah. So rest of other part of body is then you might have to go for the moderately potent, like what?
Moderately potent can be like beclomethasone.
Beclomethasone, then
Then mometasone, and more
Mometasone.
strong will be clobetasol.
Okay, clobetasone, mometasone. Okay, betamethasone, mometasone is potent, moderately potent. Clobetasone. Okay, so highly potent is clobetasol.
Yeah.
So usually, okay, for the face, only for the 2 weeks you need to prescribe, and after that, twice weekly maintenance you need to keep it. Okay. For rest of the body, you need to can go for the mometasone, beclomethasone, or mometasone, no problem. Okay. Yeah, and try to avoid, one more thing, try to avoid the triggering agents like carpet, pets, and smoking, those things, dietary factors. So they have to be avoided to reduce the number of infection, number of the attacks. So if the child is not improved, then probably you have to go up on the potential steroids and look for the complaints. And the child is having issues with the sleep patterns, probably you might have to give antihistamines, okay, for a few days. Then so if the child is not responding still, you told tacrolimus. Tacrolimus won't be given less than 2 years. Okay, I was expecting you'll answer, and you answered only more than 2 years use tacrolimus. Okay, it is 0.1%.
Child was 2 years, no?
1 year, no?
1 year.
1 year. Yeah.
Yeah.
Tacrolimus
Yeah,
calcium inhibitor is not given in less than 2 years. Okay, and
so what will be the next step then?
Steroid potency you need to increase. And
okay.
yeah, maybe try to find out maybe some food allergy. So child is, whether child is having some cause protein intolerances, then food maybe you need to avoid. Go for the hydrolyzed formula.
Hydrolyzed formula.
Yeah. Okay. So in that way you can try.
And like you were asking about cream and ointment.
Yeah. Okay, so cream is actually more of is equal parts of the oil as well as water. Okay, so in case of ointment, it's 80% oil and 20% water.
So in this case, we should prefer which one? Like
ointment, oily based. Yes. Okay, anything else, guys? You want to say something? Everyone is as close there from us.
Right.
Sharon, you are making some notes, isn't it?
No. Whatever I wanted to tell you told, sir, so it was okay.
Yeah, tell me if I missed. I'm not a Mr. Perfectionist. I might have
No, sir,
missed.
you said everything. You said everything, sir.
One more thing, yeah. So they might apply bandage also. or the
The occlusive, the
occlusion. Yeah, imagine. And one more thing.
But if the child is having a this thing, active infection, so at that time we won't apply. Actually, I was thinking of mentioning that, but that is why I.
actually, yeah, if what they say is for partial thickness wounds, you don't apply occlusive bandages. For full thickness, if there is full thickness, then you leave it open.
No, but
No,
he is
if it is
also right.
secondary
If there's
infection
active
is there.
infection, you should not cover
Yeah.
it.
You don't, that's what.
Yeah, yeah.
Active, it depends, like what is the thickness also, they say.
Yeah.
For a full thickness wound, you don't occlude. For partial thickness involving only the epidermis, dermis, you occlude.
So, but from seeing the wound, we can make out like this rash, whether it is partial or full thickness.
Yeah. Here anyway,
Is
it's not advisable because
yeah,
Yeah,
it's
it is
not
not advisable.
yeah.
Advisable.
Okay.
Dr.
And
Lavani, did you need to go up on the percentage of steroid if on the face?
usually face because you hypopigmentation happens actually. That's
Yeah.
why
Hmm.
you don't advise for the
So
more
in this case, then we there's no medical
maybe you
line.
can go up to mometasone. Okay, up to moderate
1%.
potency. You can,
Hmm.
mometasone
Yeah, but
you can
not-
go, not more
not
than
more.
beclomethasone or mometasone, not more than that.
Typically, we start with the lower potency and then see response and grade up anyway.
But for face, we will not go to very high potency.
Yeah,
Yeah, we
I
don't.
used to have a lot of difficulties managing skin condition. Believe me, guys.
Mm-hmm.
Now I'm okay. I feel. What about you guys, Rohini?
Very difficult. Dermatology is very, very difficult. Everything
Every-
looks the same for me.
Everything is the same. Correct. Correct.
Yeah.
I was just reading one chapter of Cloherty about the skin conditions in newborns just before this class.
Yeah, I agree. Okay, Deepa, you don't want to give some comments? Dinesh had given comments for you, and he is waiting for you. Where is Manisha today? Manisha disappeared.
Manisha is exhausted.
Yeah, okay. Okay, all right. One more time, you told about investigation. I agree that immunoglobulins levels, IG level, and skin prick test also, because for the food
Skin prick.
allergies, for that you need to involve the allergy specialist. Okay, I agree. Okay with you. Yeah, after this, what was the station? Next station was
Communication.
yeah,
Third
communication.
station.
Yeah, so communication. Gentamicin. So given at 24 intervals. So what do you think? How was it?
You tell.
Oh no, you have to tell us first. I will tell anyway.
It's okay from my side too.
Okay. So yeah, you touched all the things, points. I agree, but only thing, whenever question he was asking what will happen immediately, so you need to say it might affect the kidney function. However, we are monitoring kidney function by looking at the P, how much is passing P, and also doing some blood test. Yeah, and second thing, it might affect the hearing, and we will be doing hearing assessment before discharge and after 1 month again. But currently, what was the name of the baby? Jordan.
Jordan.
Yeah, Jordan is doing good, and and we are continuously monitoring for him.
Yeah, urine though I mentioned, urine and blood test. Hearing at 1 month, I did not mention.
Yeah. Okay. Yeah, I'll start from the beginning. So greeting was greeted, and you introduce yourself, and after that, it's okay. So here you don't have to congratulate, because already this issue has happened. Like, error has happened. Medical error. If you don't wish, it's okay, no problem. But yeah, is it okay to talk to you now? Yeah. Then so has anyone updated about short on? or what you know till about Jordan? You were asking do you know why I'm here? You have to why I'm here. Instead of asking that, do you know why we are here? Okay, how I know why you are alone here? Like, maybe it's okay. So you can, instead of that, like, do you know why you are meeting today? You just ask in this way. And if you ask why I'm here, then you should tell me, doctor. Then he will say, because father was looking a little bit crazy, isn't it?
Yeah. Too much angry.
Yeah, it will happen like this, man.
Yeah.
Okay, he will tell about the baby. Yes, Dr. Jordan is having some bug infection in the blood and he's on some antibiotic treatment. Am I correct? Yes, you are right. He's having bug infection and antibiotic treatment is going on in the form of gentamicin and whatever, ampicillin. So, yeah, I'm here to discuss about the uh, the error which has happened while managing Jordan. What happened? Like, to start in this way. So, the antibiotic treatment by name gentamicin, which is supposed to be given at interval of 36 hours. So, unfortunately, the drug is given at 24 hours intervals. Oh my God, you guys are going to kill my baby. How is it doing now? I'm so sorry. I apologize on the behalf of my team. So I can understand you are so much worried, but Jordan is doing good. Okay, so you were telling something. Sometimes these errors keep happening. You should not tell like that. Okay, something you told.
Yeah.
I really
Yeah, I said
remember.
very rarely this thing can happen.
No, but keep happening. Don't tell that. Don't.
Yeah.
बड़े बड़े देशों में छोटे छोटे जना जो मिस्टेक्स होते रहते हैं ऐसे ऐसे
होते
नहीं
रहते हैं.
कहो. Okay,
Yeah.
don't say that. Okay, so we always try to do the best for the babies, and we try to prevent these things happening. So what you have done for till now? Yes, I have already informed my consultant, and we have informed the nursing in charge, and we have taken it very seriously. Okay, so we don't want it to happen it again and again for anyone. So, and we are going to have a meeting about this error has happened. We have done this. So, unfortunately, I'm not in position, you can say, or you can say, I don't know where exactly the error has happened because there are so many steps involved in the system of the, drug medication actually. So I'm just trying to figure it out where exactly the things went wrong. We don't know. So while prescription, the things that went wrong, or while the drugs delivered by the pharmacy. So where it went wrong, or while giving medication, it went wrong, or we don't know exactly where, isn't it? We can't
Actually, when we had discussed this, no, so they were saying we can say it is a team failure. You cannot say the name of the person.
No, did I tell your name? Anybody's name? We don't know
No.
exactly. Okay, there are so many steps involved in this medication. Okay, we
So
don't
where
know
exactly?
things went wrong. Okay, we are just trying to figure it out and trying to correct these things. Okay, so and we have built up the critical incident form. We'll educate our staff, including nursing doctors, pharmacists. So pharmacist is clinical pharmacist will be involved here, who will be cross-checking the
There is stuck, yeah.
Yeah, sound is not coming now.
Mm.
Maybe some network issue.
Mm. Oh, okay.
You have to continue now.
Sharon, you will host now.
Yeah.
You have to take over now.
Yeah. First I will give exam, then I will take over.
My God.
So difficult to remember everything in one go, na?
Yeah.
Mm. How do you feel, Dinesh, after the marathon?
The sun has come back.
Yeah, there is.
Sorry, it was my bad network. Okay, so we'll be involving clinical pharmacists who will check, okay, who will do the cross-checking of the files for the prescription of medications, and we'll also do the periodic review of the prescription, whatever you can say. So yeah, that is how you have to say. And so father was telling doctors, I don't believe in you now. I want to take my baby Jordan to other hospital. So directly don't say take the child to other hospital. Okay, you say. So we are doing our best, and we always try to do the best for the babies. Okay, and we maintain the safety, utmost safety of the babies. So and currently it's doing good. And if you want to take the child to other hospital, it's your decision totally. However, the treatment will be same. Yeah. Okay. And what else?
For complaint, we can tell about that.
Yeah, complaint. Yeah. So how do I complain? Yeah. So yeah, you're right. You have the right to complain, and there is a department called Patient Liaison and Advice. What is that? Patient Advice and Liaison Service. PALS. Yeah. So there is a form. You need to fill up the form. I'll help you to how to fill up the form, and you can do the formal complaint, and you will receive the initial acknowledgement within 3 days, and final response you will get after 30 to 35 days. Okay. And I am again so I would like to apologize on the behalf of my team, and we definitely take care for further so that it won't happen again. So and Jordan is doing good. So is it okay? Yeah. So if you don't mind, I would like to summarize. Then you summarize. You may not get time for the summary here. No problem. You don't get time here. It's okay. It's okay.
Yeah.
Because you don't get that much, because you need to address all his concerns. That is important
Concerns.
rather than doing, summary of whatever you have spoken that time. Yeah. So you sometimes use your child. Okay. You use certain Hindi words in between. Okay. To मतलब
He.
yeah, ki to ki मतलब three things. Okay.
Okay. That has to
Okay.
be avoided.
Yeah, try to avoid these things. Okay. Did you guys
And
notice?
Yeah.
You guys.
this thing,
Yeah, this thing. Yes.
this thing as well.
Yeah.
It was also coming. It's okay.
Yeah. Don't say your child. Okay.
Dr. Lomi, I want to ask a question. Okay, I was just reading the same scenario just yesterday. It's in Mark Betty. So there they say that two complications. One is kidney issues and one is hearing issues. Kidney issues are reversible, but hearing they say is irreversible.
Agree. I totally agree. That's why I told so we have to do it again. Okay.
Yeah.
If the father is interested to know whether whether it's reversible or not, then you can say. Otherwise, maybe in the next sitting you can say. You don't have to push everything at a time. Then he will become more angry.
Yeah, because now if you say irreversible, then he
I agree.
definitely
If say it is irreversible, so then he will go out of control.
Yeah.
Yeah, he was
Already
already out of control.
out of control. Yeah, keeping him under control was so difficult.
But good. Okay, so I would like to give you Out of 8, 7. Okay.
Yeah.
Okay. Okay. After that video station, your you told, okay, so summary. You need to describe how a child, mostly I'm not able to see the child, so I would like to look for the well-being of the child. Okay, so I would like to look for the alert, awake, speech, and how is making sound or anything like that. Any small pictures.
Yeah.
So
Face was not visible in.
yeah, anything in the surroundings, I would like to look for. The child is in hospital setting, home setting, and I would like to document the time, weight, height, and head circumference. And however, looking at the video, so nutritionally, child looks okay, isn't it? So looking at the video, child nutrition looks okay. Yeah. So I could see there is a small round oval shaped mass which is moving from the left hypocontinent to the right side. Okay, gradually, isn't it? So putting all this together, vomiting, infant is having vomiting, recurrent vomiting, and this mass. So my probable diagnosis is hypertrophic pyruvate first. Okay, then gastric outlet, all DDs you need to give. Gastric web, gastric membrane, okay, valvulus you can give, malrotation you give, okay. Then dural atresia I can give, but dural atresia you might get bilious vomiting, that's the thing, like, yeah. And
And it
yeah,
will come early
yeah,
presentation.
yeah. Then other recurrent vomiting, then you might have to, like, looking at the picture of the metabolic thing derangement, you have to say, so metabolic alkalosis, hypokalemia, hypochloremia, you have to say, yeah, congenital chloral diarrhea, then long-term diuretics therapy, especially loop diuretics.
Yeah.
Okay. Then third thing is cystic fibrosis. Fourth thing is what is that? Cystic fibrosis and Bartter syndrome.
Barter.
Yeah. So these are the differential diagnosis for the metabolic picture. So yeah, and something about infantile hypertrophy. So you told about that, actually, usually male and 2 to 4 months, and they have recurrent non-bilious vomiting. Yeah. So usually after feeds. Okay. What is one bedside test you would like to do? I wanted to ask some more. I also forget. So what is the answer?
Bedside test. In that, too, we ask the mother to feed and see for that this thing. Na?
Very good. Okay, challenge. Bedside challenge.
Kind
Challenge
Yeah.
feed. Okay,
Challenge.
you give the feed and see the movement. Okay,
Mm.
so that is bedside challenge feed. Very good. This is very, very important, guys. Okay, then how do you manage? So I would like. Oh, sorry. What additional history would you like to take? So onset course progression and about the feeding in details. Yeah. So about vomiting in detail, then weight, height, and all those things. Okay, then abdomen distension, associated with abdomen distension, about the pee, poo. Yeah, so these are very, very important. And so even signs of pre-ICP, so neurological symptoms also. So family history and other thing you ask. And what additional examination? I would like to, first of all, you have to say, if the child is sick, I would like to go for the primary second assessment. If the child is not sick, then I would like to plot weight and head circumference on the appropriate coach, document vitals, and I would like to look for the perfusion, because hypovolemic shock will be there sometimes. So they are so much dehydrated. So I would like to check for the dehydration and check the perfusion. You have to say capillary fill time and peripheral pulses, central pulses, and palpate for the interfrontal. So it will be depressed. Yeah, that's very important. And do abdominal examination, cardiovascular examination. So
Is it associated with any specific cardiovascular or system disorder?
cardiovascular system disorders, it's only
It's not.
shock. Okay, hypovolemic shock.
Yeah. For general examination, we are covering that.
Yeah. Okay, then investigation wise, so you have to say, I would like to send full blood count to look for any anemia, anything is there, then coagulation parameters, because child might go for surgery, isn't it? And then if serum electrolytes, RFT, LFT, you have to say one blood gas, Okay, so I would expect hypochloremia, hypokalemia, and metabolic glucose, high pickup levels. And it's because of the loss of the H plus ions and the chlorides when child vomits, isn't it? So because of that excessive loss of the anions, so you will get alkalosis picture actually. Okay. So initially, then I would like to do an ultrasound abdomen. Okay, so ultrasound abdomen, you didn't say anything. Okay, you look for the donut sign actually, like circular.
Target sign.
Targets and donors.
Targets are a
Target
donut
sign.
sign. Targets are a donut sign. It's okay. And I was expecting, okay, pyloric musculature, especially circular fibers are hypertrophied. Circular fibers,
Yeah.
pyloric. Okay, so I would like to look for the length and breadth of the circular, basically.
Yeah.
That area. So 14/4. Remember, length more than 14 millimeter, breadth more than 4
3
millimeter
mm.
is significant. 14/4. Always I remember like this. 14/4. Okay.
14.
Yeah. So then after that, surgical pediatric surgeon, I would like to so multi-disciplinary team approach, and I would like to involve the pediatric surgeon. And initially, I would like to do medical management to correcting dehydration, electrolyte imbalance, and one child is stable. So after 24 hours, at least after 24 hours, then we can go for the pyloromyotomy. Ramsey pyloromyotomy surgery, where they will dissect the circular fibers and immediately on the same day if the child is stable, you can discharge the child also. Okay, but only post-operative complications, sometimes infection, vomiting can be there. So infection can happen. Vomiting could be there for a few hours, and you can start the feeds also the same day.
So for complications, we will just say infection and vomiting.
Vomiting, infection, yeah. Pain. Rohini, unmute yourself. You were saying something. You're saying
Sorry, I
something.
was saying they can be damage to the mucosal lining of the stomach
Yes, right.
during surgery. That's one of the
Usually
complications.
doesn't happen. Okay, then doctor is not skilled. Pediatric surgeon is not skilled. Okay. Usually the pain is the first thing. Then vomiting can happen and some bleeding can happen. These things more than enough. Okay. So 99% nothing will happen. Okay, guys. 1% they might vomit and pain will be there definitely. Yeah, so this was a thing, and Matilda. So general examination, it was good, and you try to correctly look for the local examination of skin. Very good. Okay, so you identify size, say, skin or surface, and how is that? Is it painful, tenderness? All those things you need to do. You didn't check for the tenderness, and any oozing, anything is there, ulceration, anything is there, blood. Okay, you have to ask. Then I would like to look for similar portman stains in the body, any hemangioma anywhere in the body. Yeah. Okay. Then vitals. Then you need to look for all those things. General head to toe, whatever you have to look for nicotine markers. You said pulse, blood pressure. Blood pressure you didn't forget. I think you forgot blood pressure. You forgot about that. Okay, which is important. And then yeah, so nothing. I just gave it straightforward without complications here. You might get in the exam hemiplegia, facial palsy.
Hemiplegia, yeah.
Okay, I just gave the straightforward case. So well, how do you manage the differential diagnosis?
I was starting the neurological examination because of that only.
Yeah.
I thought you will give some finding in that.
I would have given, okay, so maybe then in the gait assessment, you could have done, after general observation, you could have done the gait assessment there itself. You would have known there.
You said
Okay.
normal, gait is normal. So
then why
so
you want to do general examination task is there, you do only general examination. But while summarizing, it is say, so I would like to complete my examination, looking for the neurological examination and also facial nerve palsy, eye examination. It's very important.
What else should be included in the general examination other than the things that I covered? Or was it complete?
Yeah, it was complete. Everything you complete. Okay. And so how do you differential diagnosis facies syndrome? Okay, it's the case of Sturge. How do you pronounce it? Sturge. You are saying to Sturge. What do you mean by Sturge? Sturge. Yeah, it is Sturge Weber syndrome. You are telling Sturge. Okay.
Sturge.
Yeah. So
And you were saying more negative history. There is no hypo or hyperpigmented patches. There's no
That we
ungual
have to-
fibroma.
No, that we have to see, when we are
But in
examining the skin.
Sturge Weber's, you don't have ungual
No,
fibroma.
that is
and,
that is there, but for the skin examination, if the general physical examination of skin case, not in Sturge Weber, but otherwise.
But then
Okay.
there can be so many other different things. If you
Yeah,
start
it's
saying,
endless.
they'll ask you, are you expecting angiofibroma in Sturge Weber? Are you expecting?
No. But we cannot say that it is Sturge Weber only. No, I think like if it is a skin case, we should mention.
Okay, so basically, this areas eye and the skin here, three things. So
Yeah.
basically, you need to target for the things. Okay. How do you manage after taking focus history, documenting vitals, anthropometry? So I would like to do complete neurological examination and facial nerve examination. Eye examination is very, very important. I would like to involve the ophthalmologist first, you have to say. It's a multidisciplinary team approach, but I would like to involve ophthalmologist because acute glaucoma can develop, which can be night threatening, it can lead to blindness. Okay, so it can lead to blindness. That's why it is ophthalmological emergency. Okay, and then multidisciplinary team members you have to say, then imaging, investigation. Okay, MRI plane, CT plane. You have to look for the calcification and leptomeningeal. What is that? Leptomeningeal angiomas, isn't it? So
Angiomatosis.
angiomatosis. Yeah. So maybe. Yeah. So that thing you have to say. Then EEG might be required if the seizure is there. Yeah, agree. Then vision hearing assessment complete. You need to check developmental assessment. You have to. There could be developmental delay also. That's very important. Yeah. So you might get it for your developmental as a developmental case also. Okay. Then management depending upon the things. Okay. So read about natural history. So differential diagnosis, I agree, faces syndrome, and one more thing. What did you say?
Casabeck-Merritt syndrome.
Casabeck-Merritt.
But it has hemangioma somewhere in the body, not
usually, yeah, usually in the femoral area, you will get huge hemangioma. So, yeah. I think face syndrome, okay, other neurocutaneous syndromes, it is okay. That much is okay.
Yeah.
Yeah. What is faces syndrome?
In that we get this posterior fossa tumors, hemangiomas.
Then cardiac anomalies.
Okay,
Yeah.
PH
is heart.
Yes.
Oh, P is what?
Posterior fossa.
Posterior fossa tumors. H is hemangioma. A is arterial,
aortic arch or
yes. Then cardiac anomalies, aortic arch anomalies.
Yeah,
Then E is ear anomaly. Ear, no? What is that E? E is S is a sternal cleft. Sternal cleft. Okay. So yeah.
Sternal cleft.
And management
at the sternum area.
Yeah. So in management, you might have to involve the cosmetologist or like plastic surgeon, you could say, if they could do anything for this Portman stain. So, okay, check what they will do. So just check it out for the Portman stain. I don't know exactly what they will do for the Portman stain.
They have written pulse dye laser.
Pulse laser. Laser therapy. Yeah.
Laser therapy for Portman stain.
Yeah. Okay. All right, guys. So well done, Dinesh. So